Hi and welcome to Physiotutors podcast episode 67 with Jente Wagemans. Jente is a physiotherapist and researcher at the University of Antwerp, who is currently doing his PhD in collaboration with Ulster University and Bern University of Applied Sciences. As part of his PhD, he has published several papers about ankle sprains and chronic instability, which is the topic of today's podcast. Hi Jente, welcome to the podcast. Great to talk to you about ankle sprains and chronic instability.
Hi Kai, good morning. Thank you for having me.
Sure, it's an honor. And as always, I have prepared quite a huge list of questions. So let's start with a pretty basic question. What is a lateral ankle sprain and how does it differ from other types of ankle sprains?
Well, allow me to answer this in the same way I answer this with everyone who gives me this question, and that is, what do we actually know when a patient comes to you and tells you in the clinic, I have an ankle sprain? I don't think we know actually anything. It is often posed as a diagnosis, but it only tells a little bit about the mechanism, about where the pain is situated. But in essence, we don't know anything. But let's not make it too difficult. Mechanism-wise, it's an inversion, internal rotation, supination injury when the ankle is in plantar flexion at initial contact. And it renders mostly pain or damage at the lateral ligament complex. So the preferred term is actually a lateral ligament injury.
Okay. And how is it different from other types of ankle sprains?
Well, you have the medial ankle sprain, which is quite the opposite. You have the deltoid ligament complex that's been injured due to more pronation injury. It's not that prevalent. Others call the high ankle sprain. We don't like that term either. It's a syndesmosis injury. It's not an ankle sprain. It's a completely different injury whatsoever. And due to the mechanism, mostly it's not a supination nor pronation. It's in dorsiflexion with a rotation component of the talus into the mortise in external rotation. So there's a relative internal rotation of the fibula. So it's a completely different injury altogether. It's not a sprain of the ankle.
Okay, so this is the initial trauma. And we also said we are going to talk about chronic ankle instability. At what point do we talk about chronic ankle instability?
Well, I started my first question being difficult, so I'm just going to continue being difficult a little bit because it's a very ambiguous term, and I like to play the devil's advocate on this topic. The International Ankle Consortium standardized some inclusion criteria for research purposes with the emphasis on recurrent ankle sprain, on perceived instability, recurrent complaints, giving away episodes, and subjective ankle dysfunction. The problem is that it's still an enigma. It's a paradigm that is fueled by cross-sectional data, by case control data, and these studies in chronic ankle instability patients, these align with the representation of acute ankle sprain patients.
Yeah.
And henceforward, the art of deduction is applied, and they deduce that the one causes the other. Well, in the 18th century, we had Hume, and he said that as long as we do not observe a real causal relationship, is just an assumption. It's not because A precedes B that A causes B. So at this moment, we don't have the prospective data to underpin this enigma. And let me go a little bit further with this. Who says it really exists? the most recent model in 2019 from Hertel and Corbett, it's very comprehensive, very extensive. And they call it a heterogeneous condition, but it yields ambiguity again. It's an entire spectrum from Cooper to chronic ankle instability with a lot of options in between. Yet the current evidence doesn't explain away the paradigms. Even the very first time that a recurrent ankle sprain was reported in literature, which was in 1952, if I'm not mistaken, they talked about the mechanical part, and 2 decades later the Freeman model came. But the supposed reasons for those initial models, those initial hypotheses, are still not debunked. Yet a few new models are created, are published, with the assumption of, okay, this cross-sectional data underpins the new model, so this is what it is. Maybe it is just a recurrent ankle sprain of which the previous sprain, the previous impairments, the anatomical structures, or the psychosocial impairments are not resolved yet. Mm-hmm. So with our study, from my PhD research, we hope to solve a bit of this puzzle, but it's not an answer that we can clearly give. Okay, what is chronic ankle instability, since we don't know yet. We don't even know whether it exists.
Okay, so to summarize, an ankle sprain doesn't necessarily lead to chronic ankle instability, and maybe they could also be different things. There could be chronic ankle instability even without a prior trauma. Is that correct?
I do think that the recurrent sprain is in the center of the paradigm. Mm. I do think that an initial sprain precedes a chronic instability, although people with some kind of latency on the ligament, some kind of ligament instability, hereditary, can also cause a chronic instability. Yet, probably, if they have that instability, that mechanical instability from birth, they will suffer from ankle sprains. So it's a little bit the chicken of the egg story, and the egg story, which one precedes the other. It's a nice discussion to have, but unfortunately I can't give you a straight answer.
Okay, yeah, it reminds me a little bit of the shoulder where you have that born loose and worn loose, or the traumatic shoulders. So that might be a little bit similar to our discussion here.
Might be indeed.
And moving on, how prevalent are ankle sprains and how prevalent is chronic ankle instability?
Well, ankle sprains, and I'm going to talk mostly in sports. You also see it often in the general population, of course. The emergency departments see it very, very often. It's one of the most prevalent musculoskeletal injuries in emergency departments, and this comes mostly from studies in the USA. But in sports, is the most prevalent lower limb injury in college athletes. It's the most prevalent in the NBA. It's the most prevalent in volleyball, in the NFL, and the second highest in football. Mm. Regarding chronic ankle instability, we see numbers from one prospective study that's actually been done from Caleb Doherty in 2016 published, where Chris Bakley, one of my supervisors, was also involved, and they reported 40% chronic ankle instability.
And so that is 40% after a first traumatic incident?
Yes, indeed.
Yeah, looking at Andreas here and myself, we had a couple of ankle injuries or inversion traumas ourselves, but I think we are doing quite fine without a chronic ankle instability, right? Yeah, he's nodding, so you can see it on the camera.
Well, if you do have an ankle sprain, please participate in our study. We're still recruiting.
Oh, it's been ages, luckily, so I try not to have another one. And looking at the typical person with an ankle sprain, you already mentioned it's super prevalent in sports. Do we see any differences when it comes to gender or age?
Yes, we do. So, in essence, everybody can have an ankle sprain, from recreational to professional athletes to general active population. But in meta-analysis that's published in 2014 by Caleb Doherty again, the incidence numbers are highest in females, 2 times higher than in male population. It's also more in children than in adolescents, and in adolescents compared to adults. The peak prevalence in females is from 10 to 14 years.
Okay.
And in males is from 15 to 19 years. And this is based on a study from Eamon Delahunt, if I'm not mistaken, 2019. It comprises mostly indoor sports, court sports, sports that are characterized by jumping and landing, pivoting, changes of direction in a high pace, and of course with a neurocognitive component, which is something that aligns with other ligament injuries such as the ACL, of course.
Yeah. And you already mentioned a couple of studies, so quick shout out to all of the listeners. Don't worry about it. If you want to dig deeper, we're throwing out a lot of authors and names. You can always find the link to the studies in the podcast transcript. Following up on our discussion, do we know anything about risk factors to suffer from an ankle sprain?
We do. Not that very much, but we do have a few good studies about it, and you have the intrinsic factors that we cannot change, age, gender. So I prefer to focus on the things that we can change as a physiotherapist, that we can have an influence on. Yet again, a previous injury, we can't control itself, but we can use the injury history and the mechanism of that injury to substantiate our rehabilitation strategy. So that's one of the factors to keep in mind. Next, we have a metabolic influence, a body mass index. The higher the body mass index, based on studies that in football and American football, we see that body mass increases the risk of sustaining a lateral ankle sprain. Also muscle strength, both in the hip and the ankle, mostly the ankles, asymmetries in dorsiflexion, plantar flexion, mostly in eccentric. And I'm going to do a little bit of segue to plyometrics, because again, you see the injury mechanism mostly in landing, cutting maneuvers. Those are deep eccentric phases or a stretch shortening cycle phase, where you have to bear in mind the mechanism of the injury. So the eccentric muscle strength is definitely a big factor that plays a role in this. And I already mentioned the hip strength, but we see also a study from a colleague in Gent here in Belgium, Rolde Ridder, that if they have an impaired hip extension, also increases the risk factor of sustaining an ankle sprain. This is done in youth football. The last risk factor for ankle sprain itself, not for chronic condition, but for the acute ankle sprain, is postural balance, which is of course not surprising if we see all the literature results around balance, sensory motor function. And it is both the single leg balance test at pre-season yields a higher risk for sustaining an injury during the season, and also lower reach distances on the star excursion balance test.
Yeah. Okay, yeah, that makes a lot of sense, indeed. And you mentioned plantar flexion and dorsiflexion strength. And is there a ratio that would be ideal, or risk ratio?
Well, an ideal ratio, I have to be honest, not that I know of. I will gladly look it up, maybe to put in the transcript, but at the very moment, I can't give a clear answer. I do know that the ideal muscle strength for dorsiflexion with a handheld dynamometer is 0.4 times your body weight.
Yeah.
And if you look at plantar flexion to the soleus muscle, which is the main power generator of the triceps surae complex, we look at 1.7 times the body weight. If you look to gastroc, it's 2.5 to 3 times the body weight. 4.0. 1 repetition maximum, of course.
Okay. Yeah. So you would want to be in that range when you measure a patient, or that's at least an aim that you can work towards.
Yes, definitely.
Yeah. Okay, and then let's say someone suffered from an ankle sprain, or we want to prevent chronicity. What are risk factors to go from an initial ankle sprain or to develop chronic ankle instability after trauma?
Again, I'm going to talk about things that we can influence as physiotherapists.
Yeah, sure.
And let's start about the range of motion. Dorsiflexion range of motion is often been reported as one of the main factors, and the posterior glide kinematics, the arthrokinemaxis posterior glide of the talar bone seems to be a very important factor contributing to the development of, or having a higher risk of developing chronic ankle instability.
Mm-hmm.
Again, like with an acute ankle sprain, we have balance, a postural balance, and they looked again at the star excursion balance test and saw that the anterior, the postural lateral and the postural medial sides of the star excursion balance test, we have decreased proportional reach distances as proportional to the leg length. That also yields a higher risk. And that's actually the reason why they developed the Y balance test, which are exactly these 3 directions. Yeah. And also looking at not able to perform a single leg drop landing, a single leg drop vertical jump, which is again from the study of Caleb Doherty in 2016, the only prospective study that's been done so far. And then next, again, time to stabilization after landing, also predictor. And then the first time we see this, but I think it's something that really needs more research in a clinical setting, is the delayed peroneal reaction time. The hypothesis of the injury is that the peroneus has a latent activation during initial contact, so it doesn't co-contract sufficiently. But again, it is a hypothesis, and it seems to be a high risk factor for the development of chronic ankle instability. But it's also always been researched in laboratory settings. So I'm very interested in how we can measure this in a more clinically applicable setting that a physiotherapist can use.
Yeah, that sounds very interesting. My question would be, how do we change onset timing? It's a bit the same story with the transverse abdominis and chronic low back pain. Or do you have an idea about it already?
Actually, I do. I try to include some kind of neuro rehab, the PNFs, where you do the pre-stretch, or while doing landings, use an elastic band pulling the ankle to inversion, giving the pre-stretch during a landing task. We hope that it does whatever it needs to do, but it's underpinned by research in the neurological rehabilitation. So, and I have to be honest, I had quite good research, quite good results with this. So yeah, that's some method that can be used, but is it the absolutely correct one? I think, as usual, with every paper, with every research, we need more research to substantiate this point.
Okay, yeah, interesting stuff, though. And hey, moving on, say someone comes into your clinic and he had an inversion trauma. What are the red flags that we have to keep in mind? I think everybody is probably familiar with different kinds of fractures that we have to take into account with the order of ankle rules. What else could be there that that can be regarded as a red flag?
Well, you can have some concomitant injuries. A syndesmosis injury is often overlooked. But then again, for me, it's not really a red flag if the diastasis between tibia and fibula isn't that significant. We can treat it as physiotherapists. Although if after a while, after a few weeks, your progress is not going the way you think, then I had a habit to always communicate very closely with the orthopedic specialists to have their advice. and to inform them, okay, this is the progress we're making. Is that the way you see it as well? If not, do you think you need a consultation to check, in this case, the syndesmosis? But from the syndesmosis injuries that I had during rehab, I never had to inform them to do a surgery.
Yeah.
So in this regard, I don't think a syndesmosis injury is a red flag. Then you can have synostarcy injury, and there, to give it a clear, just a simple answer, if it shows neurological signs, because the swelling from the ligaments there can compress neurological structures. So if you have neurological signs, tingling, pins and needles, loss of sensation, then it is definitely a red flag. But again, I've never seen this in clinic, never.
Okay. Can you maybe give a brief definition of what synostarcy syndrome is? Because I think maybe some listeners out there are not familiar with it.
Well, synostarcy is just distal from the lateral malleolus, and it's a bit of a hole. How do I say it properly? I don't find the right terminology in English at the moment. And there's a ligament, the cervical ligament is going through it, which can also be damaged during an ankle sprain. And unfortunately, we don't have proper clinical tests to objectify this. You know this better than I do with all your videos about sensitivity.
Yeah, we don't have a test video on that, indeed. Yeah.
So, well, thank you for confirming. Otherwise, it would look like a fall in here. Anyway, so there can be a lot of swelling, and the swelling can compress the structures that run more profound from the synostarcy itself. The neurovascular bundle that runs more distal, more deep from the synostarcy can be compressed.
Okay. And maybe as a last one that might be a red flag, loose bodies, what about that?
Yeah, definitely. Loose bodies can resolve themselves, but indeed can cause ankle impingement complaints. So then indeed we would send them to the physician.
Yeah. And how would you suspect loose bodies in a patient? Like, what would be your signs and symptoms that you would consider a loose body in the ankle?
Well, when I saw loose bodies, it was when there was with a forced plantar flexion in lateral deviation, so more of a pronation, deep plantar flexion in a provocative compression, a very rapid compression. And that really yielded the recognizable pain that they had. So really impingement complaints, that was one of the signs to send indeed to the physician for more imaging or more specific clinical tests that are the field of the orthopedic specialists.
Yeah. Okay. Hey, moving on, In the recent years, there was a lot of discussions about, should we call it price, police, peace and love, like what should be done? So a lot of acronyms. What should be done after or directly after an acute ankle sprain? What does the latest evidence say about that?
The most current acronym is the peace and love principle, where you have the peace for the real acute phase and the love for the subacute phase. And the P stands for, of course, protection, elevation, avoid the anti-inflammatories. And I really love this statement, and it renders a lot of discussions, which I love because you gain a lot of knowledge out of it. Everybody has its point of view, but avoid the anti-inflammatories, because your inflammation phase is the first phase of tissue healing.
Yeah.
And if you're going to decrease this, if you're going to hold this back, then your entire tissue healing phases will be slowed down in the end, is the hypothesis. And I really support this, my opinion. So no eyes, no NSA days. How do you say it correctly in English? Anyway.
Yeah, NSAIDs.
Well, there you go. And then mild compression, and of course educate your patient. And I think that's the most important part of our job as a physiotherapist, is to educate our patient properly. We can have golden hands with manual treatment. We can have the best exercises ever. But if the patient is not informed properly about the injury, how it will progress or not progress, what their responsibility is to have that proper process to facilitate a good rehabilitation outcome, then all the rest doesn't matter. And maybe I'm a little bit in a privileged situation since I'm a patient right now myself, but I see myself now that the responsibility lays in the patient himself, and that is only facilitating by educating the patient properly. And then, of course, the love principle, optimism, vascularization, exercise, optimism. So optimal loading, optimism, always be positive, vascularization for the blood flow, and exercise therapy.
Okay, moving on. Say we have excluded any red flags, and we move on to diagnosis. How valuable are orthopedic tests like the anterior draw or talar tilt test? Like, what extra information would they give you?
Again, I'm going to refer to your videos. You made such a good, comprehensive analysis about these. But we just published a systematic review of measurement properties based on the ROSE guideline. And of course, the first part is indeed the orthopedic tests. And we see from the study of Van Dyck in the 90s that if you delay your anterior drawer test until 5 days, you have an increased sensitivity and specificity until 96%. So that's quite inaccurate to identify the injury at the ATFL. So it doesn't say anything about severity grading. Same goes for the talar tilt test for the CFL ligament, calcaneofibular ligament. It has only 50% sensitivity, but it has 100% specificity according to literature. But apart from those two, there are two quite new ones, the anterolateral drawer test and the reverse anterolateral drawer test, and they also have quite a good sensitivity and specificity, more than 90%.
Okay.
Again, those are for identifying a ligament injury of the ATFL or the CFL ligament. It's not to determine severity grading, grade 1, 2, or 3. Is there a possible tear, partial tear, full tear, just an elongation? That's not what we can do.
Yeah.
At this moment, part of our study is indeed to see, can we use those orthopedic tests to determine severity grading compared to medical imaging? So I hope to give you an answer very soon.
Okay. That would have been my follow-up question as well. Like, okay, then we do a test. It's positive, so we suspect there is a tear. At what point, or looking at grading, what does grading tell you for the rehab that follows? And at what point would you suggest the patient to get an MRI, for example, to be sure about what grade tear someone has or how many ligaments are affected?
Well, we can identify the injured ligaments based on the clinical tests. We can see, do we have an ATFL? Do we have a CFL? PTFL? Only in 1/8 of the time it's that one's involved. So we can identify those. And in my opinion, it's very important to consider which ligaments are involved because again, the mechanism of the injury is important, but also based on the mechanism of injury, you can know, or you can substantiate your testing protocol, and then you can strategize your treatment, your rehabilitation protocol, your rehabilitation strategy, because your ligaments need to be loaded as well. You have the 4 types of receptors, the Pacini, Ruffini, Golgi, and the pain receptors. And the Pacini and Ruffini are the most prevalent in the ATFL and CFL. And those are for proprioception, the afferent information that renders proprioception. So you need to activate them again.
Yeah.
So that's a very important part, in my opinion, and I think it's quite substantiated by literature, that we need to know which ligaments are involved. And then, of course, also the severity grading is important. If you have a full tear of your ATFL, for instance, tissue healing doesn't allow to load this immediately. So again, there your strategy is based on which ligament is involved, what's the mechanism of the injury, but also what's the severity of the injury. If you have a full tear, you have to bear that in mind during your rehabilitation strategy.
Okay. And at what point would you say, okay, now I really need an MRI because it adds any value? Because I assume an MRI is necessary for the vast majority of patients, but in top sports, you'll probably always get an MRI to check what the situation is.
They do. On the other hand, literature shows that an ultrasound can give the same result as an MRI for the ATFL and the calcaneofibular ligament. An MRI is a very expensive way of showing imaging, while an ultrasound with a good radiologist, of course, can give you the same information. So an MRI would be, for me, only for syndesmosis injuries, but for the ATFL, CFL, ultrasound can be sufficient.
And do you use it on patients regularly?
I do. It's actually part of our study. So every patient, participant that comes in, I perform the ultrasound.
Okay.
And it's always a mess. Apparently, one of the rules of doing ultrasound is that you have to be full with the substance. I don't really like that part, but anyway, not the topic of this discussion.
Okay, moving on in our conversation. So we did our screening, we ruled out red flags, we diagnosed what ligaments are affected. Ideally, we even did an ultrasound and can maybe say something about the grade of the tear. I guess then it's all about our functional assessment and to figure out what the functional deficits are. We already touched a little bit on that, I guess, during our conversation about risk factors. How would your further assessment process look like?
Everything. I try to test everything from range of motion to muscle strength to balance. But after the first phase of rehab, I have a little bit my own algorithm from a subacute phase more to a functional phase, return to activity. I get more functional. So I try to replicate the needs of the patient with my testings, going from walking down the stairs for activities of daily living. And again, there we come to its deceleration phase, eccentric loading. But to look more into sports, we have several hop tests. We have drop vertical jumps. We have standing long jumps or moving long jumps, lateral jumps, agility testing. And of course, it's always being devil's advocate. They don't replicate the needs of your sports. They don't expose you to the needs of the sports. So we can only test so far in a clinical setting and try to include a neurocognitive component as much as possible. And at some point, getting them out of the pitch on the pitch, or playing one-on-ones with team members or a fellow patient, or even yourself as a physiotherapist, is more of a test than all the functional test batteries that we have out there. On the other hand, it's not very an objective criterion how the patient performs in a one-on-one or in a scrimmage or in a full training. On the other hand, I do believe that the patient's perception of feeling ready is one of the main factors. We can't objectify it, it's very subjective, but if the patient feels ready for going back on the field, full training, starting in a game, or as a substitute, I think that says most. It says more than all the functional test batteries that we have in current literature. And I think I repeat what a lot of people say about the ACL, and we have the same thing there. Hop tests predict this, or agility tests predict this. But the conclusion is, again and again and again, they don't replicate the loads and the exposure that the athlete has. So it's the same in the ankle.
Yeah, I think we're going to go only so far with testing in a isolated environment as a physios. And like you said, on the pitch, on the field, it's always different. So we try to come as close as possible, but there's never a perfect replication.
Unfortunately not.
And moving on, so you do your assessment, you assess a lot of different things you mentioned, from ROM to strength training, but also functional strength to functional daily activities. Can you take us a little bit through your management approach? Let's say from the acute phase, so it's a pretty broad question, from the acute phase to return to sport. How could your process look like?
In the acute phase, the aim is mostly to reduce swelling, reduce pain, and from the scratch improve quality of life. And the strategy is, of course, the peace principle that we just mentioned. And we look at no reactivity, reduce the swelling as much as possible. The inflammation signs actually should be decreased as much as possible. Yeah. We monitor the pain, we monitor the reactivity, and then gradually going on to a subacute phase where my aims are mostly promote the tissue healing as much as possible with vascularization. One of the exercises that I give to everyone, although my strategy is always patient-centered based on testings, there's one exercise I give everyone from the start, and that's going on a bicycle. In the acute phase, just unload it. It's an easy way to have vascularization and repetitive movements. And if you have a dorsiflexion range of motion deficit, you can put the seat lower and lower, so they have to go into that deep dorsiflexion. So it's a combined exercise for one range of motion, but also for vascularization, promoting your tissue healing process. So that's an exercise I give to everyone with an ankle sprain. Then, of course, work on your impairments based on the clinical tests that you have performed, and preferably as objective as possible. Don't do manual testings. The weight-bearing lunge test is an easy way of objectifying dorsiflexion range of motion in already a functional setting. But you also have very low budget inclinometers or goniometers to really objectify range of motion in all directions. Muscle strength, it can be either isometric, or you have via pulley systems that you can do 1 RM maximum. Actually, a paper published about this very recently, that there is a reliable way of testing 1 repetition maximums for eversion and inversion via pulley system. And also the stride, the gait patterns are included from the start. And again, movement quality, so including neurocognitive tasks from the start on. Even if they have to do exercises seated, try to include neurocognitive exercise. And maybe, as a quick example, put resistance band both for inversion and eversion, and based on a color that comes on the screen, they have to do the one or the other. It's an easy way of training the brain from the start on. More proceeding into functional phases of rehabilitation, I look again restoring those impairments, but in function of the functionality. So then I'm going to look more to what's your sports, what's your position, what are your needs, what are your requirements, what's the exposure you will have. And I will start training the impairments in function of those things. So you have functional mobility exercises where you would start on the table, for instance, or on a bicycle. You can now do it in a more functional setting. The movement task would go from static to more dynamic and challenging, start running with proper periodizations based on the necessities of the sports, going backwards but also forwards but also backwards, looking at eccentrics and decelerations, lateral movements, medial movements, increasing the speed gradually, and also going more to functional strength training. I just mentioned deceleration, so also eccentric training for proper load absorption, muscular endurance, but also gradually working towards power, the plyometric continuum from strength to power, but also from very rapid and unloaded movement working towards power. So you have both of the force velocity curve endings working towards the power and a power middle of the force velocity curve. And I'm going to emphasize this because I'm afraid that it's often overlooked, the role of plyometrics and force velocity training, force velocity based training and ankle rehab. I know an ankle sprain is not an ACL or an Achilles tendon tear or meniscus injury where you have several months. And especially in elite athletes, it's only a few weeks that you're working on them. Yet you have a deloading principle due to your injury, and they have to be reloaded to the load capacity that is required for their sports. So including a force velocity profile is again of paramount role into this rehabilitation. It's not because it's only in a few weeks instead of a few months that we don't have to include it.
Yeah. But
then, moving on total body power, it's not only the ankle that need to be trained. You have a kinetic chain, your postural balance from a more controlled environment to more dynamic and chaotic neurocognitive tasks, and then landing strategies, since most of the injuries happen during landing. And then we come to a return to activity phase, where you really work through those activities, running tasks, to changes of direction, agility, quickness, sport-specific, preferably with already a companion or the physiotherapist, making it also a little bit entertaining. Rehab can be fun as well, in my opinion.
Sure, yeah.
Sport-specific stability training, hopping, jumping, landing, external loads, and external perturbations, since very often it's like a semi-contact injury. In football, you have mostly the contact injury after a tackle. We all know injuries such as Neymar and Mbappe that had a very big tackle on the ankle. Our own Dries Mertens a few years ago had a severe tackle of Virgil van Dijk. Yeah, the hair comes up from thinking about that again, but we can't do anything about it. But we do have that semi-contact injuries where you have proximal perturbation, shoulder push or whatever, bring you out of balance and you land incorrectly and you have that sprain. So most perturbations are proximal, not distal. So balance boards are very nice, a very good tool in early stages, but the perturbations are proximal. So use, for instance, water bags here, or one that I really love to do, and the patients hated it, but I really loved them for it, in all honesty. We have to be a little bit of a sadist and enjoy it, is put a barbell and with elastic bands and different types of weights, so every time they land, it really brings them off balance. But if they
do this one as well, indeed.
Yeah, it's a very lovely exercise, isn't it? to observe, not to perform ourselves. So yeah, stuff like that. And then go into reactive training, plyometrics, change of directions. Again, I know I'm repeating myself, but the neurocognitive part is such an important factor. And then gradually expose them to training to match and hopefully a successful return to sports.
Yeah. And what is the role of taping or braces? I mean, I'm watching a lot of tennis now with Roland Garros on, and you see a lot of players who still wear braces or tape on their ankles, even though they might have never had an ankle sprain. But what's your take on that?
Well, your fellow countryman, Evert Verhagen, did very good research on this. Is a very nice fellow, an example to us all. So I really invite everybody to read his work or have a chat with him. He really knows a lot about these topics, well, about everything actually. But based on those studies and the experience I had, I recommend semi-rigid bracing. And then again, we come to the education part. The patient should know that it's only a small influence. If they think that the brace will solve it all, they will get disappointed rather quickly. So I need them to learn that their influence, their work on strengthening and stabilizing the ankle is going to yield the best possible outcome. Bracing is just an extra. So if I have a patient with an ankle sprain, I do advise the bracing, and then that we gradually increase the bracing. Let's start, for instance, with a training where there is no contact first time. And if they felt good, if they felt confident, we can gradually decrease the brace. So they learn to have the confidence in their ankle themselves, and not to have the confidence in an external support such as bracing.
Okay. And how high is the recurrence of ankle sprains?
You see this properly. It goes until...
It's probably higher than I would guess.
What's your guess?
Now, if you phrase it like that, I'm saying 40%?
47% in volleyball.
Oh, actually quite a good guess, but it's very high indeed.
Yeah. 43 in handball, also above 30 in tennis, basketball around 30, American football high in the 20s. Indeed, very high recurrence rates.
Yeah, I did have at least 3 or 4 myself while playing soccer actively, so I would probably fall into the 47% as well. And is there anything we can do as athletes to prevent that? Or how can we lower that high number?
Well, I'm going to be a little bit bragging this time. We published our own meta-analysis 2 years ago that exercise-based rehab decreases the risk of having a subsequent ankle sprain. So the main take-home here is exercise-based rehab, do your exercises. And in those programs include the impairments and the mechanisms of the injury. And that will already get you a very long way. Okay,
that's a very good message, and I think I definitely lacked doing that back in the days. I don't think we had that good of a physio support. But there's also people who or keep on suffering from recurring ankle sprains. When would surgery be considered?
In lateral ligament injury, mostly I wouldn't consider it. Even a grade 3 injury, I had a patient with a really severe tear both on the calcaneofibular ligament as the ATFL, and we were able to get him back to competition, full competition, of course in a longer time than an elongation. But if rehab really fails to improve the impairments, fails to improve the perceived instability, the subjective ankle function, quality of life, and you have really persistent ankle sprains, recurrent ankle sprains, giving way episodes, then I would indeed consider having a talk with the orthopedic specialist for a Brunstrom Gold procedure. I'm not going to elaborate on the procedure. I think it's best that we ask a surgeon about this. But like I said, I tend to discuss the cases quite closely with the orthopedic specialist, so I never had to. There's one patient where we came close, but in the end, he improved rather rapidly, and then it stagnated for a very long time, which really frustrated the patient.
Yeah.
And he had a few recurrences, so at some point we were really discussing with the coach, myself, the orthopedic specialist, and the patient, like, look, we are stagnating, you have recurrent sprains, what do we do? And then the first possible appointment was like 2 weeks later, and yet then the improvement started. It was a bit early to say he didn't have recurrent sprains anymore, but we really started to feel like, oh, my balance is going better, the tasks that you're giving me, I can perform them better, my range of motion is getting better all of a sudden, the swelling is decreasing. So it was really astonishing that at the moment we planned for an appointment to discuss a possible surgery, he got better. So in the end, I called to the orthopedic specialist. I said, look, this and this and this is now happening during the course of 3-4 days. What do you recommend? And we canceled it. The orthopedic specialist herself canceled the appointment. And we went on, and henceforward, until now, he didn't have one more ankle sprain. So it was quite an astonishing event that after 4 or 5 weeks, no progress, all of a sudden, all the pieces of the puzzle fell in their place, and he improved really, really significantly in a short amount of time.
Yeah. So with this guy, maybe probably he exceeded the average recovery time. What is the usual recovery in terms of days and weeks? Do we have any data on that?
We have data, and the data shows that most athletes return to sports in 10 to 14 days.
Yeah.
The problem is that at that point, your phases of tissue healing are not in the stages of having the proper load tolerance, which may underpin why the recurrence rates are so high. So I'm afraid I can't give you a very clear answer on this because we have so many confounding factors here. We see in our study that most return to sports around 70 days. And our criteria for successful return to sports or the return to sports day is that the subjective feeling of being able to perform 100%. And in our study, we see that it's a preliminary result, of course, because we're only halfway. But we did preliminary analysis last week, and it shows that around 75 days, most return to sports. But is that a good answer regarding an average recovery time? I'm afraid that at that point we have return to sports time points, but again, other publications report that those timings are too early because there's still impairments that are not resolved. So again, I hope that our research will give a few answers regarding this question.
Okay, and if a patient feels 100% ready to perform well, that's a quite subjective criteria for return to sport. Mm-hmm. Are there also objective criteria that you use?
First thing is they can have no more positive clinical provocative tests for the ATFL and the CFL. So the involved tissues really need to be healed. Or they need to be loaded. We know from research that ligaments, they heal so many weeks, months, years. But again, they need to be loaded. They can't be provoked anymore for the recognizable pain that they had from the initial sprain. Then, based on measurements, the impairments found need to be recovered. And what is recovered, you can have thresholds from literature, like I said, for soleus muscle strength 1.7 times body weight, or dorsiflexion 0.4. But you can also look at minimal detectable change between the two limbs. 90% limb symmetry index is also often used. Is that a proper value? I don't know. I prefer to use either thresholds, but even more so pre-injury data. I had the privilege of working with athletes that were always tested pre-injury. So we had those data where we can work with, and then able to perform functional tasks in neurocognitively challenging settings. As I said before, agility, jumping, landing, including sport-specific double tasks based on the needs of exposure on the field. And it's not objective, but their mental readiness is paramount importance.
Okay, I'm looking at the list of my questions, and I have asked you all of the questions on my list. So at the end of the podcast, we're always saying, is there anything that we haven't touched on that you would like to add, or is there a question that you were missing?
Well, I do want to emphasize that I don't want to stretch the importance of an ankle sprain. It's not an ACL. It's not an Achilles tendon rupture or things that really need surgery or need months of absence from play. Yet again, it's also not that innocent. So just give it its proper attention. Don't return to play your athletes, your patients too early, or think that it's just ubiquitous and just walk it off. Also to physicians sometimes, and I'm still early in my career, so I'm not going to school any colleagues or physicians or whatever, but the advice of just put your foot high in some ice and next week you can do whatever you want again. I'm afraid that's one of the messages that can have an effect on the re-injury. Advise your patient properly, consider it properly, rehab it in the best way you can, and we will have good results.
Okay, great. Thank you so much for all of your answers. And if there's listeners out there who would like to get in touch with you or read and see more from you, where can they find you?
You can find me on LinkedIn or Instagram. I'm not that active on social media, but I do respond to messages. So yeah, everybody can be in touch. Also, if you do have patients with acute ankle sprains, please send them to us so we can recruit some more into our study. Still ongoing, needs about 100 more. So please get them coming. I want to do something else in my life than only this study. So everybody who wants to contribute with sending participants to us would be lovely.
Yeah, you're lucky that it's such a prevalent injury. Could have been worse.
Well, you'd be surprised. We're now recruiting for over a year and we only have 48 recruited participants. It's not that easy, actually. When we initially started with our feasibility study, we discussed it with surgeons, with other therapists, with GPs and the like. And they said, easily 10 per month. So in a year, you will have your sample size. Yeah. And now a year further, we're at 1/3 of the expected.
Yeah.
So it's apparently not that easy to find. We do have quite strict criteria for eligibility. But then again, considering it's such a prevalent injury, normally it shouldn't be a problem.
Yeah, I wish you all the best with your studies, Jente. And also with this being said, I would like to thank you so much for your time and for your knowledge and for coming on to this podcast. It was a pleasure to have you. And also thanks a lot for everyone listening. out there. As always, to access the transcript and additional resources, make sure to download our new and free Physiotutors app. You can also use the web app, so no need to download anything, and benefit from more useful physio content. And if you enjoyed this episode, hit the subscribe button or follow our podcast on Spotify or Apple Podcasts, or like mentioned in the app already, where we can offer different languages for the podcast even. Also consider leaving a review if you really enjoyed it. And with this being said, this was Kai for Physiotutors, and I'll see you in a next episode. Bye bye.